Good afternoon. Shall we start this session? Okay. So, we are going to start the session on lamellar keratoplasty, basics and beyond. So, I am Dr. Shish Kumar, and with me, the moderator is Dr. Shreyas. He is in the other theatre. He'll come. And I have a panelist group. Dr. Vanadi is here. Okay. Dr. Satyamurthy. Dr. Satyamurthy is a senior cornea refractive surgeon. Please come over to the dais. From MM Joshi Eye Hospital, Hubli, and of course he is the director of MM Joshi Eye Hospital in Dharwad. And I have Dr. Manoranjan Das. Dr. MRD? Okay. Fine. So the theme is the lamellar keratoplasty, basics and beyond. We all know lamellar keratoplasty has become an automatic choice for the management of diseases of cornea which requires keratoplasty. Wherever it is indicated, that has to be done. But of course, there are still certain indications wherein you have to go ahead and do a penetrating keratoplasty. So let us start with the first topic. That's on indications for penetrating keratoplasty in today's practice by Dr. Devadatta Das. Dr. Devadatta Das is a prolific cornea, cataract and refractive surgeon from Bhubaneswar. He has his own centers in Bhubaneswar and Cuttack. So over to you, Dr. Devadatta.
Good afternoon to all the panelists and to all the speakers in the forum and to all the respected doctor audience present here. I am going to present a topic. It's an indication for penetrating keratoplasty in today's practice. I am Dr. Devdutt. I am from Bhubaneswar. My topic is like discussing a thing where a grand old master is still coping up with the pace of the recent generation and is a guide for the future intervention and is a savior in the time of crisis. Penetrating keratoplasty ranks among the oldest of the successful keratoplasty procedures. Zim performed the first successful corneal transplantation in 1905. Literature reported indications for PK significantly vary between the global regions and over time. To be noted here is, although the number of performed PK procedures is decreasing because the newer lamellar transplantation methods have been developed, but PK is still an important and necessary surgical procedure, particularly when newer surgical methods are not proving to be reasonable or they fail to achieve the purpose. The classical concept of keratoplasty procedures, where the discussion was going on between penetrating keratoplasty and lamellar keratoplasty, is if the corneal opacity is involving the full stroma of the cornea and there's a poor endothelium, one would go for penetrating keratoplasty. And if the stroma is involvement with a good endothelium, then one is going for lamellar procedures. Again, the classical concepts were there, where only corneal edema and scarring was there with a poor endothelium. People were going for penetrating keratoplasty, and on the other side, when the corneal edema was only present but with a poor endothelium, people were preferring to go for endothelial keratoplasty. Surgery per se, this is a very short video. This is ring has been put. The cornea is being cut with adequate marking. This is actually a triple procedure, but I'm showing it is a penetrating keratoplasty procedure also. You can see the graft is being put. The sutures are being put, and inside there is an IOL with in the bag placement. As per literature, the most common indications for PK were keratitis and corneal scarring in Asian subcontinent. Keratoconus was more common in Europe, Africa, Middle East, Australia, New Zealand, Central and South America, and bullous keratopathy was there in North America. Classifying the indications, still today, the indications can be classified into three groups: optical, therapeutic, and tectonic. In optical, as everybody knows, keratoconus has been now a party between bulk and penetrating keratoplasty, but when the cornea is too much thinned out, like cases of acute corneal hydrops, PK is the option of choice. And corneal degenerations like severe pellucid marginal degeneration with inverted bell sign is an indication for penetrating keratoplasty. And for the corneal refractive surgeons, progressive post-LASIK keratectasia is a indication for going a full thickness keratoplasty. This is automatically a choice. Full thickness corneal scarring post corneal tear repair in whichever age group is a choice for going for a penetrating keratoplasty. Full thickness corneal scarring after infectious keratitis, there's a discussion between DALK and PK, but I've seen in conferences and my seniors that they're happy with penetrating keratoplasty. This is another controversial, the corneal dystrophies like macular and lattice. This also swings between DALK and penetrating keratoplasty, but the options are individualized. This indication, full thickness congenital corneal opacities involving in Peters anomaly, sclerocornea, CHED, and corneal dermoid. This looks a topic of presentation, but it's a difficult procedure to attain success because the younger the children, the worse the survival prognosis of the graft, and the complication rates and graft failures are higher in younger age group. Therapeutic is full thickness, microbial keratitis, especially the recalcitrant ones, whether it's bacterial, fungal, or viral, and perforated corneal is anyhow the choice for going for a penetrating keratoplasty. Graft infection or interface infection of lamellar procedures is usually difficult to manage, especially if it's fungal, and may require therapeutic penetrating keratoplasty ultimately. Tectonic, as the word sounds, it's the non-infectious full thickness ulcerative keratitis like the PUK, which has its both infective and immunogenic, is an indication. Whether you can go also penetrating keratoplasty, you can do DALK also, but the problem is here the survival of the graft is very difficult and it becomes very difficult to survive the eye. This is anterior corneal staphyloma is another indication for going for a PK. Corneal melting post Lyme injury. This is also a survival procedure. It's very difficult to manage because saving the globe and saving the cornea is a very cumbersome procedure. Like others, where we go for a regrafting of a failed or a rejected graft previously done for a penetrating keratoplasty. And indications here is intraoperative big descent membrane tear in DALK. I have seen my seniors in conference also and in live surgeries also. If a DALK goes for a big perforation, usually it's converted. But here I went to literature where it's written Sugoto and Kondo reported this complication in 39.2% of their cases, but none required conversion to PK. This I would like to discuss with my seniors. But till date, with all the immunological medications and the drops available, endothelial graft rejection in PK is still highly relevant, especially in the high-risk settings. In comparison to all the procedures, intraoperative and post-operative complications are higher in penetrating keratoplasty, and recovery and rehabilitation time is still longer as compared to other procedures. Thank you.
Thank you, Dr. Devdutt. It's a nice presentation. I have a few questions for the panelists. So, Dr. Satyamurthy, so what is your first choice of surgery for healed hydrops patients?
No, in case if the scar is there at the center, the hydrops in the center, the desmal stare, then probably, as Dr. Das suggested, I would go for penetrating keratoplasty.
Exactly.
If it is in the periphery, then I'll try DALK first and then.
Yeah. The DALK actually gives good results. Definitely, we can try DALK if it is possible. If the scar is right in the center, of course, we have no choice. We have to go ahead and do a penetrating keratoplasty. And Dr. Manoranjan, in case of advanced macular corneal dystrophy, which procedure you would like to do?
I would definitely prefer to go for a plain PK.
In
Yeah,
advanced
because
case?
almost all these macular dystrophy in cases they go for endothelial involvement in these advanced cases.
Yeah.
So it is better to go for a 7.5 over 8. That should be the ideal size for
You
the.
would like to do anti-segment OCT and then confirm it and do it, or
Yeah,
you
if you
straight away
got
go
that
ahead?
modalities, it is fine. But also it is very clinically clearly evident.
Okay.
You can see the endothelial changes, and if it is endothelium is not involved, then it is also a choice, of course. But as a late macular dystrophy, definitely I would love to do a PK.
Okay. And in any case of bullous keratopathy with the scar on the surface, what is your choice of surgery?
Bullous keratopathy with scar, if it is not involved in the visual axis, so it is paracentral. You can still do a lamellar surgeries. And if it is like a scar involving visual axis and there is scar also in the posterior stroma, then usually it doesn't help. Even the DSEC also, we have seen a lot of cases we do DSEC with paracentral scars. What happens with due course of time, within 1 year time or 2 year time, the scar appears to be fading. And also the DSEC lenticle also modulate itself. If you put a 150 microns of DSEC lenticle, which you are doing now, so by the time you cover it 1-2 years, that DSEC lenticle appears to be 70 or 80 microns. That is corneal remodeling is so good. So if it is visual axis, then you have to think twice. If it is paracentral, let it be white spot, doesn't matter.
Yeah. So just with that thing, many times I got this thing. So can we do PTK for the surface scarring later on? First do DSEC and then do PTK.
So I have never done it, sir, frankly speaking.
No, I mean just.
Yeah, if it is superficial, we can do PTK up to 150 microns. That means around 100 microns after deepithelialization. If the scar is restricted to the 100 microns, then you can do a PTK, and at the same time you can have a posterior lamellar graft. So that definitely can be tried. Yeah, Dr.
So paracentral, your definition as for the macular and the scar in bullous keratopathy, what is the zone you are referring to? Paracentral
is
more
beyond,
than,
yeah, it is always beyond 5 millimeter.
it's beyond 5
Yeah,
millimeters.
beyond 5 millimeter. Because most of the astigmatism and most of the best corrective visual acuity is centered around the 5 millimeter of the refractive zone. So if it is beyond 5 millimeter, you can have any choice.
Thank you, sir.
Yeah, there's still a controversy. Macular corneal dystrophy, if it is a end stage macular corneal dystrophy, if the patient comes to you at a 5th decade or 6th decade, it's better you go ahead and do a penetrating keratoplasty. And if it is a young patient, not very advanced, definitely we can go ahead and do a dark in these cases.
Yes.
Good. Thank you. Thank you. Any questions in the audience? Okay, the second and third speakers, they are having some commitments in the other hall. So we'll move on to the fourth topic by Dr. Mallikarjun. So intraoperative DM perforations in DALK. How do I manage? So Dr. Mallikarjun is a senior cornea refractive surgeon and he is a chief at Shankara Hospital, Shimoga. Over to you, Dr. Mallikarjun.
क्या झाला ना आहे ना हे जर आहे ना Good afternoon, everyone. At the outset, I would like to thank Dr. Srisha
and Scientific Committee of AIOS for this opportunity. I'm going to talk on intraoperative DM detachment or DM perforation in DALK management. This is the most common intraoperative complications, and it has been reported 4 to 39%. And it can even happen in most experienced surgeon also. And it is attributed to range of corneal pathologies, because if the pathology like more advanced corneal thickness, there is chances of perforation is more, and thinner corneas, the perforation is common, and if the severe keratoconus, again the perforation will be more, and sort of choice of surgical technique and experience of surgeon. These are all the contributing factors for the DM perforation. It can happen in all the stages of surgery. It can happen during trepanation, while air injection and stromal dissection, and even while collapsing the big bubble. That time also it can happen. And most commonly during it can happen in suturing, especially in novice surgeons, because there will be emphysema in the periphery. While if they take a suture, full thickness suture, there is a chances of microperforations. And it's very important to differentiate between microperforation and macroperforation. Micro is less than 1 millimeter and macro is more than 1 millimeter, but you cannot usually make during the surgery. You cannot measure it. The one guideline is if the air stays inside the antechamber, it can be and it doesn't collapse, it can be a micro perforation. And if air collapses outside and it escapes from the antechamber, it can be a macro perforation. So the management differs depending on the size of the perforation. And management depends on the size of perforation, as I said earlier, and location of perforation and stage of perforation. One golden rule is don't get panic. Recognize the perforation and you have many ways of managing it. This is a one case. I have achieved a big bubble, type 1, and over enthusiastically I am trying to excise the Duas layer. See what happens. I make a small nick to excise and I end up with the perforation there. So if you look at the perforation, it is a smaller perforation, and I assess the perforation there. It is little bit away from the visual axis, and this can be managed just by putting a air tamponade in the antechamber. You can put air in the antechamber and continue with the surgery. And it is, since the air bubble is fully occupying the antechamber, can you play the video, please? Because it is air is fully covers the antechamber, at the end of the surgery, you should not leave a whole air bubble. So you have to take out the air bubble, because chances of pupillary block and Urey-Chevalier syndrome, all those are common. And also, you should look for the post-operative double antechamber. So this is a one more case. This is a case of failed big bubble. See, there is an emphysema of the stroma, and I'm trying to do a lamellar dissection and end up with a perforation there. But this stage, in this patient, the stage, it has happened the early stage, because a lot of stroma is still there, and it is a periphery. So what I do is I start dissection from other side of the perforation. So not at the site of the perforation. And in these cases, you have to repeatedly fill up the antechamber with air. And so at the perforation area, I dissect it at the last and put the graft and suture it. And of course, air has to be there in the antechamber while suturing. This is one interesting case. See the done by our fellow trainee. What she did is while dissecting and while trepanation, she was trying to extend the groove and ended up with perforation. So this can happen during trepanation also. So that time you just suture the perforation. You have to put a full thickness suture, and here it's a little bit more. I have put a 3 suture there, and try for a big bubble, and even big bubble can be achieved in such cases. I got a small big bubble at the center, and I dissecting the anterior stroma and end up with the perforation again. So this patient has a double perforation. So one during the trepanation, one during the dissection. So still you can continue, and the big bubble has been released, and slowly the remaining stroma, with the help of iris repositor inserted into the interface, it is removed. And again, the dissection should be last at the perforation side. What you can do here is, at the perforation area, you can leave behind small amount of tissue there. So that would give us some sort of a tamponade there. And over that, put a graft and suture it. And you can also use a fibrin glue when there is a microperforation. You put a fibrin glue, seal the perforation, and suture it. This is one novel technique that has been described in Journal of Clinical Ophthalmology. Here, there is a microperforation here, and air is escaping out. And what you can do is, whatever excised tissue is there, you put it on the perforation and suture it, and put a graft over it, and complete the suturing. At the end of the surgery, just pull it out, that whatever the patch graft you have put it. So in conclusion, most of the DM perforation during DAL can be managed without converting to PK. Thank you.
Thank you, Dr. Mallikarjun. It's a nice presentation with the nice videos. And it's one of the commonest complications, as we all know, perforation, microperforation or a macroperforation, and it can happen at any stage of the surgery. And identifying the perforation is very important, and so that you can save the decimates, you can continue with the DALK. And the type of bubble also is very important. If you get a type 1 bubble, the chances of perforation is less. If you get a type 2 bubble, chances of perforation is high. A type 3 bubble, chances of perforation is high. Identify these bubbles, and you continue your surgical steps accordingly. So usually what I do is, if it is a type 1 bubble, I straight away go ahead with the big bubble technique and continue with the DALK. I just collapse the bubble and do the dissection and continue with the DALK. But suppose if it is a type 2 bubble, it is better you go ahead and do a manual DALK in these cases. Type 3 bubble, again you go ahead and do a manual DALK so that you can avoid that perforation. So, do you agree with this, Dr. Satyamurthy?
Yeah, correct. I mean, what you said is just correct. Again, the site of perforation also matters.
Yeah.
And then one thing I want to know is how do you use fibrin glue here? I mean,
how you use?
yeah, you just put it over the perforated area, and
Yeah,
then
you
over
have
that you put the graft and suture it, or what is it?
You have to just put it over the perforation area, sir. And if it is the perforation is very large, still it doesn't work because it won't stay there. It might seep into the antechamber. And also the perforation should not be a linear one. If it is a linear cut, then again
no,
it won't
no,
seal it.
yes, I
So somewhat like a perforation, somewhat it has created some tunnel-like thing that sometimes when you take a sharp
Tunnel
instrument and there it will seal better. So usually what I do, I leave behind small tissue there. I don't, because it will cause some amount
Madam,
of
please come.
astigmatism, because there are many ways to manage the astigmatism post-operatively. So you can leave behind small bit of tissue over there and continue the dissection. Earlier I used to convert them. Earlier most of the perforations I used to convert, but in recent past, there are many ways to manage the perforations.
Oh, right.
Dr. MRD, when do you convert?
Yeah, I usually convert
Okay.
when it is larger than 2 millimeter.
Okay,
Otherwise, even for 1 millimeter, 2 millimeter, I put a suture and do it. And I have seen with my hand, I also get perforation in type 2 when I just want to decompress.
Yes, yes.
Type 1 is not a problem.
Yeah.
You can just continue like that. So type 2
Mike,
only-
Mike.
sorry. Type 2 only, sir, if it is more than 2 millimeter, I simply convert.
While collapsing the
Why
bubble.
I just, and then I feel very bad. But type 1, if it is there perforation micro, I don't bother, I continue.
Yeah, that is a very commonly happens because it's a very sharp instrument you use. But one thing what you can do, you put a bolus of viscoelastic there, bolus of viscoelastic, and so it will be little bit guarded like thing. So you won't put a more pressure. If you put a viscoelastic and through the viscoelastic you try to collapse, the chances are little bit less.
I feel, sir, it has the amount of the size of the bubble is more important.
Yeah.
Sometimes we feel get about 4 or 5 millimeter bubble and we try to decompress. And
And
that
also,
is the time I get
yeah,
problem.
also there is a bubble and also there is air in the antechamber. So all of the things, it will be very tense eye. Very tense eye. You just try to collapse it, DM suddenly comes up.
Yeah, yeah. So it should be done carefully. It has to be done fast and like whenever there is this perforation, if it is in the periphery, you will leave that area and come to the other area and continue your dissection. And then towards the end only you dissect the area where there is a perforation. If it is a large perforation and most of your dissection is incomplete, it's better you convert. If it is a perforation is right in the center, if your dissection is not complete, and it's better you convert it. That is the only indication. And okay, I think Dr. Shreyas has a talk on healed eye drops, so we'll move on to the next topic. Dr. Shreyas. So a case of advanced KC with scar.
Thank you so much, sir. Thank you for having me as part of your course, and it's nice to follow, sir. There's a lot of preamble already given to this topic on how to manage the bubbles, and I'll try to add a little bit more about keratoplasty. So obviously we have two major options when you have advanced keratoconus, whether to do a DALK or PK, and when you're doing a DALK, whether you would go for a big bubble or a manual dissection. So this is a patient with a significant amount of apical scarring. Previous contact lens wearer, now not comfortable with the scleral contact lens and wants to undergo a DALK procedure. In all these patients, we do an anterior segment OCT, and as you can see here, this patient is just an apical scar. There is no eye drops, and the DM is very much intact. There is a very little gap between the scar and the DM. These are patients who are very much amenable for a big bubble procedure, and after using your initial trephination, some surgeons directly like to go in with the DALK. I like to remove the anterior lamella and then go ahead with the big bubble. Generally, tips to achieve the big bubble is to ensure that you go paracentral. It doesn't have to be very deep, but once we reach the paracentral area, slightly dip down, you will feel an initial resistance, and once you see that resistance, you know that you are going to achieve that big bubble, because the bubble then percolates down, it starts spreading, and then it goes all the way to the periphery. There are two things which I'd like to describe here. If the bubble does not go all the way to the periphery, then you actually end up having a smaller bubble in the center, which ideally you can put in some viscoelastic and enlarge it. This is just that bolus of Orogel or cohesive viscoelastic which I put on top, and then I'm ensuring that there are no additions. Now since this was a big bubble which has gone right up to the trephination margins, I'm able to do this directly with the spatula. But in case it has not gone on, you could even expand it by injecting viscoelastic into the space so that those additions between the posterior stroma and the DM are separated, and you can easily go ahead just with your Dahlk scissor and go ahead and cut it and remove it very easily. In case you get a type 2 bubble, something which I wanted to add was very often in these type 2 bubbles, fortunately they're not very common, but they tend to expand beyond your trephination margin and you have a loose redundant DM in those cases. Happens more with some of the dystrophy patients than in keratoconus, but still in these patients, once you're finished with your Dahlk procedure, you do well to fill the anterior chamber with air bubble so that it opposes again. Otherwise, very often you'll have this hanging DM and you have a double anterior chamber the next day when you have a type 2 bubble, and then you can go ahead with the procedure. Most of these patients have a pristine interface and do extremely well, and you can see that the ASOCT is also fairly uniform. There's no interface haze. Now, this is a patient who has had a post-hydrops, and there is a post-hydrop scar, and you can see in this ASOCT, as opposed to the patient who had just the apical scarring, this is an eye where the posterior layer DM has been disrupted. Now, once you have waited a sufficient period for this to scar down, usually this does not extend. But again, attempting a big bubble would not be a good idea in these patients, and generally what is recommended is a layer by layer dissection. Now, initially getting a good trephination with a vacuum or a manual trephine is important. Using a vacuum just gives you that extra level of comfort in terms of reaching a particular depth, and then you can deepen it, make the groove as deep as possible. Now, there are two ways you can approach. Either you can go on deepening it all around the periphery and then make it sufficiently deep and then remove it in a single layer. The only challenge is the visibility sometimes reduces when you go to the other side. So this is a technique which I prefer, where I generally, the anterior first layer can be removed directly even over the central cornea still, because there is some thickness left. But once you go on to the next layers, now this is just a little bit of dissection going beyond the trephination margin, because in these advanced cones, you can tuck in your graft a little bit, and the suturing, when it goes into that groove, the graft nicely tucks in, and then you don't have any malapposition. This is something which I prefer to do. So in the central area it is thinner, but the peripheral area is thicker in these corneas. And ideally you want to have a very smooth uniform bed rather than having an uneven bed. So the dissection should be carried along all around the periphery, and the central area is usually not dissected till the very end. So basically we are just concentrically removing circles of tissue around the central thin area, whereas we are leaving the central thin area over the area of hydrops, which is possibly only around 200 microns left intact. And then in the very end, as you would see here, once you have reached a very close to the predecimes, it peels off very easily. Without even dissection, it will peel off. And in this dissection, all you're doing is just separating those fibers. You're not really dissecting, and it is very, very smooth. And once you've reached that particular plane, you can go ahead and suture. Now, the important thing to discuss here is, I'm just sure won't run through this video in detail, but it's just to show that this technique can be repeatable, and you can do this any number of times and keep peeling off the tissue, and this works very well in any of these very advanced keratoconic patients where you can't do a big bubble technique. But what I wanted to highlight in the next couple of slides is, while you may have a little bit of residual stroma, mild folds in the interface, this usually goes away with time and it integrates. And you can see here, there might be slight differences from the center to the mid-periphery despite whatever care that you've taken, but this compacts over time. And as you can see, it is almost gone after a month's time from the initial graft, and that residual is gone. And you can achieve good topographic results, good BCVA, even after these dissections. So just a quick couple of slides on big bubble versus manual. Big bubble gives us faster visual recovery and greater consistency in our results. But studies have shown that manual, while there is a slightly slower recovery, if the residual tissue is less than 70 microns, the final long-term results are comparable to that of big bubble in terms of visual acuity. PK versus Dahlk. Rather than leaving the patient with a very irregular bed with a thin center and a thick mid-periphery where the quality of vision, the interface haze is very high, you do very well to even convert them to a PK in case you're not able to achieve a smooth layer. Yes, we would try to attempt a DALK first, but even with PK, these patients have excellent outcomes and the survival rates are very, very good. So we always try to attempt a DALK with irregular bed. Don't have hesitation to convert to a PK, even in the last post-operative period. Not immediately, but let's say 2 to 3 years down the line, still the patient's interface is not modulating. A PK will give them excellent results. Thank you so much for your kind attention.
Thank you, Shreyas. It was a nice presentation, nice videos. One question.
One question,
Yes,
Shreyas. Would you like to deflate the anterior chamber
I think
while doing the dissection?
Yes, madam.
I think that will help in.
In the manual dissection, very often I don't deflate, madam.
Okay.
But whenever I do a big bubble, I always make a peripheral, neck stab incision so that the pressure comes down. And before I actually put that viscoelastic and open up that bubble, I always deflate. This actually gives a lot of control, even if you are putting a little bit more force while doing that anterior nick. It does not make a problem because the DM does not come forward rapidly.
Even in manual, if you, I think if you do your side port and put a small bubble in the anterior chamber, that again another one reference
for the
thing.
depth. Yes,
Yeah.
madam. Yes, madam.
Quick question. Yeah. Nice points which you elucidated, Shreyas. And one particular thing is how do you decide on your graft sizing in these patients? Because that's particularly important. And I particularly do find, because we are all doing DALKs only for advanced keratoconus, which we are not able to probably fit, considering that a lot have already been cross-linked here. And when I do a same sizing or a 0.25 sizing, I do get those folds, which you did show, those interface folds. And when they come right on in your pupillary axis, of course, the thickness of your residual bed goes down with time, but those folds do interfere with your quality of vision in the postoperative. So that's something I think I'd like to hear.
In fact, it happens even with big bubble DALK, and I find that it happens more with big bubble DALK than with manual DALK.
It is more with big bubble DALK. So I have started sizing my grafts 0.25 or 0.5 over, even in advanced keratoconus, even when my pre-op myopia is more than 6, because that's the learning dictum which we go through during our fellowship. But to avoid this interface wrinkles, I have started doing this.
I completely agree, madam. And it is so much easier to treat the postoperative myopia than to end up with a flat graft, which is very, very difficult to treat in the postoperative period. Thank you, madam.
Any questions?
No, just one adding point is that probably says this is the case which you saw that stromal scar or deep stromal scar was not that deep. Probably I prefer to do a central debulking last, because even if you do layer by layer dissection coming out in concentric rings, if you got a dense scar, then the central debulking, if you do it last, then it will be more predictable, because this didn't have any scar as such, although it was nicely seen in OCT, ASOCT, but the scar density and the amount of density and the size of density was very small, so you could happily manage. But that doesn't happen for each hydrospecific post-hydrop scar. So these cases, I always
addition might be different.
To debulk the center last. You clear up all around, and then these cases
and peel off the center at the very end.
Safe.
Yes.
I usually inject air into the stroma. It is not to achieve big bubble. It is just to create an emphysema of the cornea. It is not directed towards the tear, the healed tear. It is directed towards the periphery. So it helps in the dissection. So I create emphysema in all the cases.
That emphysema also provides an idea of the depth of our dissection, and it is a good idea. Only challenge is when we don't want a big bubble, we shouldn't end up with a big bubble when we inject the air. That's
the next topic is on the corneal. Old corneal scar, healed corneal scars post herpetic keratitis. Dr. Revati. Dr. Revati is head of the Department of Cornea Refractive Surgery and a senior surgeon at the Arvind Eye Hospital, Coimbatore. Over to you, madam.
Thank you, Shrees. And maybe like what Mano raised that point, whether to do a emphysema, whether to attempt to create an emphysema in presence of a scar, maybe my technique will answer that. And because this is specifically mentioned as a post-viral scar. So any scar when you plan to either do a DALK or PK, first we should know whether at what age this scar started and whether there is a chance for amblyopia here or not. And the depth can be assessed as pointed out already by ASOCT, and also whether there is in vascularization, any irregularity in the thickness and lipid deposits and secondary degenerations, and the associated ocular surface health, how is it, and most importantly corneal sensation we have to assess, and then only we have to plan. And we have to prepare these corneas for surgery. And if there is vascularization, we have to try to address that first with either Avastin injection subconjunctival all around, or intrastromal cauterization, or injecting mitomycin into the vessels. Now it's being promoted, but we have to do it very cautiously and control the inflammation and epithelial problems which will allow the vessels to regress. And lipid deposits, once the vessels regress, it may go off, otherwise very difficult to manage. And most importantly, corneal sensation has to be assessed. If it is grossly decreased or anesthetic cornea, then we have to address that first before touching this cornea for any kind of keratoplastic procedures. And in case of established viral etiology, we have to give antiviral coverage oral to start with at least 2 weeks or even before the surgery, and then continue that. And we don't know how long we have to continue. Generally, even up to 1 or 2 years, it will be continued to avoid the recurrence and the graft failure. Then come to my technique. What I do is hydrodissection instead of using air effort to dissect, because this will give a controlled swelling of the stroma, so that it will not give away suddenly, and the hydrated tissue will be more pliable and wet for blunt dissection also. So this is the technique I follow. Though you see two linear Y-shaped scar, this is a post-viral only. The surface looks like that. And then once I do the regular partial trephination, instead of injecting air, I inject the normal irrigating fluid, or you can use distilled water, but I generally use irrigating fluid. And you can see how very controlled way it goes for a hydration. It's not a sudden expansion. Then you can do the same layer by layer dissection, and this hydrated tissue will be more pliable and easy to dissect also. I use the closed, then you can again one more time you can inject here. You can see the actual hydro big bubble is forming in the interface. Luckily this scar didn't go up to the endothelium or Descemet's membrane. Then you can use the blunt instruments to dissect, and then use the scissor itself. The closed edge of the scissor is we can be used as a blunt instrument, and then you can use undermine the tissue, and again layer by layer we have to go patiently. And because I was very sure the central scar is not going up to the DM, I even went for the central dissection boldly. But otherwise you have to, as Mano pointed out, you keep it for the end. And here this is the last stage, so I am very careful in dissecting the central area. Then you almost get the Descemet's, expose the Descemet's almost all around. And then after dissecting, then the rest of the procedure will be the same. And you can see the anterior chamber air bubble is remaining same only in the place without any problem, and the interface will be almost like after your big bubble technique. So that's how like I do this in these cases, any scars. And the epithelial, because it's addressed as a post-viral, you expect epithelial healing problem, and you have to differentiate this whether the recurrence of the viral keratitis or the simple epithelial healing problem, and then you have to manage it. Sometimes you have to add antiviral. Of course, oral antiviral coverage we have already given, and we have to support sometimes even a temporary torsorrhaphy may be needed to help in epithelial healing. And then whether in the presence when you see a edema like this later, you don't know whether the viral component occurred or the endothelial rejection. Again, whether to add steroid or not is doubtful, but you have to continue. Oral steroid adding will be better than topical directly and with the antiviral coverage. So in conclusion, PK or LK can be attended even in these cases, either for optical or therapeutic purpose. Graft survival in case of viral keratitis will be, if it is established one, will be poor. Even in 3 years follow-up, it is only 60 to 70%. And recurrence of HSV also is more common in these cases. So doing the surgery technique alone is not important here. Preparing the patient before and taking care of the problem later is a challenge, and only with that we have to keep in mind before taking these patients for surgery. Thank you.
Thank you, madam. It's a nice presentation, and your technique is also very good. But how do you what is the difference between your technique and the technique what we usually do? That is a big bubble air injection.
Yeah.
There is a scar, but still does it give any extra advantage over the big bubble technique which we usually do?
Yes. When you inject, what Mano raised, that big bubble, even Shreyas mentioned, you want to create some kind of, even in scar, some kind of emphysema, but if you don't have control over the bubble formation. So if you reach and the bubble started forming, I have seen it many times, even in scars in keratoconus, suddenly somewhere it can give way. Or the type 2 bubble. See, in hydro, type 2 bubble is, I have not seen. I am doing it routinely for these cases. I have never seen a type 2 bubble with the hydro. So this is a very controlled, slowly progressing hydration. And the tissue is swollen very nicely and very pliable. And again, like air emphysema, here also, you can see the gradient. Like when you reach the more clear cornea, all the stroma is being removed, when you reach the endothelium also. And the tissue handling, if you try, you will know the tissue handling is really very easy here. It's not a dry desiccated tissue as in air bubble technique. Boldly you can see, I use even the scissor itself to dissect. You can easily do that even when you go near the Descemet's membrane. And especially post hydra cases, if the scar is not exactly in the center, if it is paracentral, I do this technique. And even all around I inject. When it comes to the scar area, I stop, and then all around I can dissect and come, and in that area I can do it. You can leave behind even a small amount of scar in the deeper layer and go ahead with the dark.
And how is your antiviral prophylaxis?
Generally,
this is actually a specific case of herpetic keratitis. But any scar, other than if the patient doesn't give any history of any injury or any other ulcer formation, if he comes with a scar in the cornea, do you give acyclovir prophylaxis in these cases? There are some surgeons invariably, like if they see a corneal scar, if there is no history, they give acyclovir prophylaxis. Do you agree with that?
I think there is no harm in giving when you don't know about the history, but sometimes we can make out a post microbial suppurative scar will be more dense, full thickness, all these things. But still, if you are in doubt, there is no harm in giving antiviral prophylaxis. Of course, later on maybe you can taper it earlier. You can stop it earlier and see again.
Any comments?
Madam, I have got one question, madam. Is there any role of AMG in all these cases with the combination of the after PK is DALK is over?
In viral cases?
Yeah, viral cases, madam.
So far, I have not seen the need for it. If you do, if the ocular surface is otherwise okay. But if it is an anesthetic cornea, I won't even touch for the surgery.
And any role, any recurrence of interface vascularization or lipid keratosis, which is mostly the vessels will be there.
Viral keratitis can recur, of course. And the problems you mentioned can occur in any vascularized cornea, even a failed graft.
No, madam, you have mentioned that how long the post this thing, viral should be, antivirals should be given, valsicloprid. So how long normally, what do you practice?
I try to give even up to 1 year, because
year.
that's where graft rejection also is more. But if it is a DALK, of course we are not bothered about the rejection that much. But I have seen stromal keratitis recurring even after DALK, even after many years. Maybe again you have to restart. But in DALK, I think maybe, I don't know, it's all rough. There is no literature evidence for that. Maybe up to 6 months like that we can give. But it's a well-tolerated drug, oral valsiclovir. Dr. Vanati, what is your experience?
I think first is preoperative. The telltale evidence is that it is a viral or a herpetic pathology. Is you would have differential thinning, which is present along with your scar, along with lots of sensations, and a prior history of periodical redness and diminution, and a treatment taken on in case you find your history is not reliable here. And in such cases, I give a postoperative antiviral therapy. I do start it, I try most of the time to start it preoperatively itself. And I do take them on for a minimum of 1 year or 18 months if it is tolerated. As you rightly pointed out, I think there's no evidence in literature to say or to recommend for how long you can give antiviral therapy. But I think most of the what we have in literature is that they've given as much as 18 months or so. But I do agree with you that giving your antiviral therapy certainly probably decreases the morbidity of the recurrence if it does occur, but it's not 100% foolproof that it may not occur here. I've had cases myself who have been on antiviral therapy in penetrating keratoplasties and in lamellar keratoplasties who have had recurrences here. And I think these, when they do have recurrences, they tend to be more morbid and they tend to scar more in these, and definitely you do cause, it does result in a decrease in your post-healed visual outcomes in these patients. So that's something which we still are trying to understand, and I don't have a clear-cut definition of how long you can give, but I give it for as long as the patient can tolerate it. Yeah. Introduce Suresh. You can
Now I request Dr. Sheesh Kumar to speak on the topic.
Good afternoon. My topic is phaco and Fuchs endothelial dystrophy. So it's actually on grade stage 2 endothelial dystrophy, but
to your mic because they're recording the session.
Yeah. So we all know Fuchs endothelial dystrophy is like an autosomal dominant type of dystrophy. It's a non-inflammatory condition, and before going further, we should know what are the stages of Fuchs dystrophy. Stage 1 is actually American Academy of Ophthalmology staging, and stage 1 to stage 4. Stage 1 is actually you see a few central guttae and the patient is not symptomatic, visual acuity is 6/6. If there is a cataract, of course it can affect the vision, but otherwise the corneal condition will not affect the vision, and the patient is not symptomatic. Stage 2, the patient is symptomatic. They will have a mild to moderate loss of vision, but without any irritation, pain, photophobia. But the patients can have moderate to severe corneal guttae and mild corneal edema, and the visual acuity can be affected 20/20 to 20/80. And stage 3 and stage 4 are severe grade Fuchs endothelial dystrophy, and here you can see confluent corneal guttae, moderate to severe corneal edema, epithelial bullae, and moderate to severe vision loss. And stage 4 is a stage of scarring, subepithelial scar or fewer epithelial bullae in the periphery, and you can even see a panstromal scar in these cases. So the grading is important, and then you can decide about the type of surgery you want to go ahead when you are combining with the phacoemulsification. So this is a case of stage 1. Actually, you can see there is amount of edema. It's between stage 1 and stage 2. The patient is slightly symptomatic, and And when you are doing phaco alone, you have to take certain measures, and it's ideally you should do a sclerocorneal tunnel because the peripheral cornea is almost normal. You don't want to disturb the peripheral cornea, which is normal. Create a central rexis and do phaco emulsification in the back. And this is actually I'm doing a chopping technique, direct chopping technique, and you divide the nucleus into multiple fragments. So you make it 7 to 8 segments, and try to emulsify it, and gently you do, and replace the antechamber with the viscoelastic substance or high molecular weight viscoelastic substance on and off. Don't allow the chamber to collapse. uh, and then go ahead and aspirate the cortex, and see to it that your the irrigation port is not directed towards the corneal endothelium. It should be sideways or on the iris plane. Inject the lens and place the lens inside the bag. Remove all the viscoelastic substance during the IA, and go behind the IOL. Remove all the viscoelastic substance, and any post-operative rise of IOP has to be avoided, and don't tighten the chamber too much. And any rise of IOP post-operatively also can cause damage to the endothelium. This is how it is pre-op and post-op. There is change in the endothelial cell count, but usually these patients can manage for at least 3-4 years. But cases like this, you have a significant edema, the patient is symptomatic, and the visual acuity is affected, and your specular microscopy picture shows this picture. No cells could be detected, mainly because of the corneal edema. So you have to combine it with either phaco with DSEC or DMEC. I prefer DSEC for the simple reason that I don't have excess tissue. I buy tissues from eye banks, so I don't want to experiment on that. My DSEC, I never waste any tissue. DMEC, there is a possibility I lose that tissue. So desmetorexis, stripping of desmets has to be done in these cases because the endothelium is thick. The endothelial desmets complex is thick here because of the abnormal collagen deposition. And some cases like chronic PBK, I usually don't do a desmetorexis in those cases. But in this case, I do it. See to it that it is not extending to the periphery. Sometimes your graft the area, there will be clear cornea, but the periphery you have bullae that it will be disturbing for the patient. So see to it that it doesn't extend to the periphery. And I use a sheets glide for all the cases. It actually, we can, even in the collapsed globe, you can use this technique. And this is the post-operative first day and 6 weeks post-operative picture, and the anti-segment OCT picture of the same patient. So you can even go further down and use a thin graft. You can go up to 450 microns and prepare a thin graft lenticule. And of course, the handling of these thin grafts is similar to handling of PDEC graft. Not as difficult as a DMEC graft. I usually stain these thin lenticules so that identifying these tissue in the antechamber will become easy. Yeah, this is a thin graft, thin lenticule you can see here on day 1. So it's the results are as good as DMEC or PDEC in these cases. So we have to identify the stage of Fuchs, and if it is a stage 1 and the patient has cataract, you can go ahead and do a phaco with the viscoat. If it is stage 2 and stage 3, you can do phaco with the DSEC or DMEC. And my preferred technique is DSEC. We have a talk on DMEC by Dr. Siddharth, the next talk. And if there is a subepithelial scar or if there is a panretinal scar, a pancorneal scar, then you have to either plan to do a phaco with the DSEC, DMEC or PK. If it is a dense scar, you have to do a PK in these cases. Thank you very much.
So it is our extreme privilege for me to introduce Siddharthan, a versatile surgeon, and he's the best person probably to discuss about the DSEC and DMEC, why and how to choose the which surgery is best for what patient.
Thank you, Dr. Sirish, for giving the opportunity here to talk about in DSEC and DMEC. I think we had an extensive discussion on DALC and PK and how to convert, and I think it's a good topic to talk about DSEC and DMEC. I think now endothelial keratoplasty is more often seen as a refractive procedure. So that's why slowly it's moving from PK, DSAC to DMAC. So 10 years ago, when we had a problem in the endothelium, we were replacing all the 5 layers of the cornea. So it was really, what to say, very primitive procedure for when there was an endothelial problem. And then in 2003, when DSAC came, it was such a big boon because there was no issue of managing astigmatism, suture related problems, and it was really a very great leap for an endothelial keratoplasty. And after this, in 2006, when DMAC came, it had the perfect anatomical replacement of the endothelium, and it had a better refractive outcome when you compare it with DSAC. So indications, there are a lot of indications when you take a book or when you take a journal, there are a lot of indications. But for me, I feel that DSAC is very ideal when there is no iris tissue, and when there is moderate stromal scarring means that you're not able to see the DM graft inside, then it's better not to attempt a DMAC. DMAC when there is an endothelial dysfunction and mild stromal scarring or a typical endothelial scarring. When of course there is a significant scarring, you have to go for a PK only. So this is what everybody says in DSEC. Whenever you have these type of recipient related issues, for example, with a high myope, it's a vitrectomized eye, aphakia, blebs, large pupil, irregular anterior chamber death. When the young donor tissue is there, everybody prefers DSEC. I think 90% of people, they feel DSEC is more comfortable. Of course, I also accept the same, but DMAC is, as you start doing more DMACs, these surgeries are really, it helps the patient to achieve a better refractive outcome. And DSEC, of course, we need a lot of all these equipments like artificial anterior chamber. You need a crescent forceps and all these things, endothelial forceps. You need a sheaths glide. You need a lot of equipments for a DSEC. Whereas in a DMAC, it's just a normal Sinski hook to separate the DM and a regular curved forceps and any prototype injector which are available 500 to 1000 rupees, it's available. So I feel the rate limiting step, as we had read in chemistries and all these things, the rate limiting factor in endothelial keratoplasty is the corneal clarity, the iris and the pupil. If a corneal clarity is good, if the iris is normal, and if you have a regular pupil or even a larger pupil, you can do a pupilloplasty. DMAC can be attempted. The advantages of DMAC is the more anatomical result with no optical interface, faster visual recovery, lower rejection rates, and better refractive outcomes. So most of the studies have shown that the recovery of DMAC, visual recovery, is about 3 to 4 weeks when compared to a little bit more in the DSAC. And the presence of the optical interface is likely to limit their acuity. So DSAC is in these type of procedures, in this case, DSEC is ideal. DMAC is not at all ideal. It's only about choosing the patient. As I told you, the rate limiting factor is the iris and the pupil. When in this condition, I'm trying to see whether there's any possibility to do a pupilloplasty. Obviously, there is no use here. So when in these conditions, should never attempt a DMAC, because DMAC will never work, because the moment it touches the IOL, it sticks on to the IOL and you cannot unfold it. And even if you heroically unfold, there will be a lot of endothelial cell loss. And so it is better DSAC is done in this cases. So as I told you, if there is no iris, if there is no pupil, please go ahead with DSAC, because it gives you very good results, and it is really a the patient benefits a lot. So these are very good cases where we have done very beautiful DSACs here, and the results are really good. The only one factor which I always think is that when the vision improves, the final visual outcome, the 6 to getting you 6.6 or 6.9, it's not always possible in DSAC, because there is a definite element of stromal hair. There is a stromal bulk there, where it causes a little bit shift in your refractive power. So why there is a hesitation? Even Dr. Sirish was telling now that he's such a good surgeon, such a Dr. Revati ma'am, all of them are such good surgeons, but as Dr. Sirish was telling, nobody wants to waste tissue, because that's so much of this thing. Nobody wants to waste tissue. So the problem is, like previously, the understanding the orientation of roll, how to remove the DM without damage from corneal layers. The injector, still now there is no prototype injector, and as everybody is comfortable with the older technique of DSAC, and still there is nobody who can say that DMAC has a standard procedure like a DSAC. So, but when you start doing DMACs, so when I started in 2013, started doing it, I also had a lot of problems. But you see that when you start seeing the results, when you see the amazing no interface, the clarity, I thought of doing, in most of the cases, I tried doing it, even in regrafts. A lot of smaller adjustments you do, and you get very good results. Even in eye syndromes, I think published in academy last 2 years back, and I think now for even in eye syndrome, DMAC is really now becoming the choice, because you cannot put, because AC is already irregular, and you don't want to put an additional load of stroma inside there. And the key point here is, even if you release the PAS, it will get adherent. So try to do a graft which is lesser than the PA. Suppose it's only 6.5 the clear zone, do a 6.5 mm graft. And important thing is, take a older tissue. The choosing the tissue is very, very important. You should, in these type of complicated cases, you should choose a tissue above 50 years. If you put a 30, 35, 40-year-old, it's not possible to open up. And particularly it's easy, as the AC is very shallow. So once you put it in, it actually really very nicely unfolds. And this patient actually, I was actually in Shankara, so I could see her. This was about a 3 years post-op, and now about recently, last week she came. She was almost 7 years, almost 6 to 7 years post-op. Her endothelial cell count is now around 1,200 or something now. And even in scars like these cases, I'm not advocating DSAC or DMAC, but what I advocate is just try to attempt and see what is possible, because this is a completely a fibrosed epithelium, and more of a endothelial scarring here. Actually, when you do a stripping of the decimus, you can see that once I remove the DM, you can see that it's now the antechamber is much more clearer, because the problem lied in the epithelium and it lied in the endothelium. The stroma was actually better in these cases. And so then after that, I go ahead with a regular regular DMAC procedure. So here what I did is, I put air to see for some time whether the cornea cleared, and obviously after some time the cornea cleared. So then I thought, okay, I will go ahead with the DMAC here. So the procedure is the same how we do, and you can see the results here. So almost a completely pre-op scar, second day, and 6 months post-op. Really had a very good visual acuity. She was improving to almost 6.12. She was not improving to 6.6. She was improving 6.12, and she was much happy. And this is a case of post-shunt aphakia, and we did a iris claw with DMAC, and this is again a eye syndrome with a IOL done elsewhere, and we could do a DSAC. And even PBK with post IOL vacuolation, go for an iris claw with a DMAC, and even large post therapeutic grafts go with a DMAC graft, and even eccentric or hemi grafts we can do in DMAC. And even these cases, hopeless cases where we see so much of vascularization, actually DSACs are indicated, but DMACs, this is a DMAC actually, and you can see that 1 year the vessels, everything cleared so very well. So, and another thing which I wanted to show you here, this is actually a high myope, a young 30-year-old tissue. It's only the technique actually. I have not put any suture here because usually high myopes, as you try to open, it will become deeper. So here just a modification, I have not put any suture, just tried opening it and it opens. So the thing, as we say, high myopes, young donor tissues, all these things DMAC cannot be attempted, but we can definitely attempt. So in my experience, I feel transition from DSAC to DMAC is just like PRK to LASIK. That's what I would say, because we have in recent years, we say that there is still a place for PRK, and still many surgeons prefer PRK. So it doesn't mean that LASIK is bad, but still PRK is a very good procedure. DMAC has a very steep learning curve, but this should be preferred in most endothelial diseases. DSEC is definitely has a definite but limited indications, and it need not be abandoned. It definitely is one of the latest innovations in endothelial keratoplasty. Of course, keep this one point in mind when you do decide between a DSEC and DMAC. The visual quality and quantity is definitely better than DSEC. Thank you.
I think
Dr. Siddharthan, when you do the complicated cases like FAK, IC, how long you want to keep the bubble in the anterior chamber? Because doing the procedure on table like
Yes,
these videos,
Madam,
it can
what
be done,
I
but
generally
later.
do in all the cases, madam, I do an inferior PI. I keep a full fill and I do not release it at all, madam.
Okay.
I do not release at all, because with that I feel out of 100 cases, only 1 or 2 goes for rebubbling. Otherwise, as many people say, you release the air. In DMAC, that is the most important thing. DSEC we can actually release, but in DMAC, I have never released unless next day I see and the air is still full, and that time only I release, because doing an inferior PI has made our life very easy, because obviously even if you don't need to keep it rock hard, but if it is full, the next day by 5-6 hours it goes beyond the pupillary. So I never release the air at all.
Another problem I faced in vitrectomized eye.
Yes, madam.
You leave even full bubble on table in a supine position. Next day you can see that it goes into the vitreous cavity.
Yes,
Such
madam.
cases, what you do?
Madam, if it's an SFIOL, it is better to do a DSAC only, because the air definitely, as you say, go back. That's why if it's an iris claw, it actually closes the pupil. And sometimes what we advocate normally, like if you put air, vitrectomized eyes, the air actually goes behind the IOL also. So sometimes we fill air in the vitreous also, you fill air, it goes in. So the next day from the vitreous, the air comes into the thing. But the one chance is there is a chance of pupillary block is definitely.
Even in iris claw, I come across in a vitrectomized eye. That's
Yes,
why
ma'am.
I asked.
I think excellent and very bold DMAC procedures, I think, which can be done only by a surgeon with a lot of experience handling such cases here. And I think you rightly pointed out the limitation in converting from a DSEC to a DMAC is that we do not want to waste tissues, considering we do have long lists, at least in institutes like ours. And two is we don't have a standardized prototype in terms of an injector here. So can you elaborate what do you feel will be the least cost effective injector which you would advocate for our
now
people who
what
are
I have
learning?
been using is just a Technis cartridge, that injector, you cut it, and then an IV tubing, that syringe, and 1 cc. It's 15-20 rupees. So I think that is more than enough. All these, and I've been doing that for the last 10 years. And okay, whatever the count, whatever they say, it is okay. And I feel I take a C cartridge from the Technis, because the smaller the roll, the lesser the exposure, because the endothelium is actually outside.
Yes.
So the more the scroll, the lesser the touch. The bigger the scroll, more touch.
More.
So the more it is scrolled, it is better. So I feel that any injector is, even a 3 injector, you can take a 2.8 injector is better because it's better of a scroll inside, and the amount of tissues in time it's inside is also very less now. So I don't think there is any it's just hardly 20-25 rupees injector. And one thing which I advocate everybody is, now what I have been doing is, I do a DALK, I take the tissue, and if they are really scared about DMAC, they can have a defect tissue, they do a DALK, that DM they can use it for DMAC. So that's how nowadays I do. One tissue I use for 2 patients, and that too after coming to private practice, eyes are costly. So when we can actually use it too, it is really cost effective also.
Yeah, but sometimes dark we go for even B grade corneas.
Yes, madam.
There we can't do this.
But what I'm doing, 45-50-year-old tissue, very ideal, madam. 45 to 50, the DM also comes off very well. Only thing, actually, you have a therapeutic quality. You just keep the tissue so that you transfer the DM into this thing. And one more thing, if it is 40-45, we think of putting it into the other tissue for support. Endothelial cell loss is there, but if you're doing a 50-55-year-old tissue, the count is less, whereas in a 40-year-old tissue the count is 3000 plus. So actually it doesn't actually matter, and I've seen those actually. Initially when I started doing, I did not do for like VIP cases and all. We didn't want to transfer a DMAC DALK tissue, whether it will fail, but the counts were really good only. Maybe we'll lose around 300 to 400 cells, but
maybe with once you dive into that, you will get the enough
yes,
courage to go and do it.
I feel that is the only thing, madam. Actually, people like you, I've learned so much surgeries from you. So I think it's only the mind that thing, that DMAC tissue going waste, and that is
Wonderful presentation, Siddharth. And you have shown one case wherein you preferred DSEC over DMAC. So that is a clear indication for DSEC. But any other indications wherein you want to do a DSEC rather DMAC?
So even CHED, sir. CHED, I would prefer to do a DSEC only, because the view is really very bad, and it's a young patient. So better to give some 16 to 20-year-old tissue for that defect. So that condition also I would prefer to do a DSEC only, sir, because DMAC anyway above 40, 35, 40. So I think a CHED is one thing, is another indication. As you said, it will be one of the indication for CHED, for DSEC will be CHED also.
One last question to Dr. Revati. Now, what is your experience of DSEC in SHED?
Yeah.
Have you come across any Bowman's membrane
Striae,
folds,
yeah,
striae?
yeah. It was Dr. Muralidhar showed that, and I have done few cases. I have not noticed such severe Bowman's membrane folds or anything. But in CHED, as Siddharthan pointed out, DSEC is better. I have done DMAC, and luckily, it worked also. But I think ideally we should go for DSEC. And one thing Dr. Basak always used to mention, the thickness, preoperative thickness. Even in SHED, some of the cases will present with, even in very earlier age, they will present with the bullae, very thick and opaque corneas. Such corneas, I think we have to be careful. Maybe in such corneas, you get problems like this.
Just one last question to Siddharthan. Siddharthan, what is the special precautions you take with this irregular AC in eyes? Because I have seen, I don't, not much, but 3-4 cases. What happens if what I realize that when you graft of small graft, even if it is 7 millimeter and it is eccentric, it is not exactly the central, in eyes it fails. Whereas in DMAC, if it is a routine DMAC with IOL, then it works out. Here, little bit eccentric graft with pass all around already pre-existing, it fails.
Sir, the key point here is identify which area is clear, because you have PAS most of the area. Which area is clearer, you have to put the incision at that position and enter and go into the graft. So that is very important, because if you see a slightly superiorly, you have a clear area. So that area you have to choose. As you're telling, if PA is 360 degree, where you will enter. But you have to see a place where the graft can go. It can be a little bit nasal or superior, whatever, or inferior. So that is very important, sir, because that is one thing. And my experience is I do not release a PAS because it bleeds and then again it forms. So you go a slightly, suppose it is 7 mm, it's clear. You take a 6.75 or 6.5 graft, put it in, and that is better. Anyway, you go for PK or DSAC, you have to tell them, sir, but you have to tell them that you have to repeat it. You will get glaucoma. You might need PK. Everything. This is only a temporary procedure. You buy time. That's it.
Thank you, Siddharth. I thank all my panelists and all speakers for this wonderful interactive session. Thank you very much.
Thank you.